components, but in general, as is always the case, you need to know all of the bones, including the bones of the wrist or proximal hand out there, which we will probably have time only to go over very rapidly. Now, remember this upper portion is called the shoulder. It's the movements of the shoulder that we discussed earlier in the semester include such motions as protraction, retraction, rotation, important for regular, everyday, as well as athletic movements. There's a little animation here.
The scapula does not have a bony articulation with the axial skeleton. Its movement affects the upper limb and is controlled by scapular muscles. Elevation of the scapula raises the shoulders. For example, when one shrugs the shoulders.
And you know how to test for that neurologically? Because you know what nerve innervates.
Depression of the scapula lowers the shoulders. For example, when one's shoulders sag. Protraction of the scapula moves the shoulder forward. For example, pushing oars forward during rowing. Retraction of the scapula pulls the shoulders backward. For example, pulling oars toward the body during rowing. Upward rotation of the scapula directs the glenoid cavity superiorly or upward, as occurs during abduction of the arm. Downward rotation of the scapula directs the glenoid cavity inferiorly, as when lowering the arm from above the head.
So be familiar with those movements. We want to talk a little bit about the muscles responsible, or at least assisting for some of these complex movements. So be familiar with that terminology. By the way, little thing isn't working here. By the way, that is an AP revealed animation or video there. So a lot of these videos that we use in class are available from the McGraw-Hill resources. I encourage you to take advantage of them. And then we'll talk about the movements of the elbow and wrist a little later. There's the motion or movement of the elbow and the wrist is considerably more limited with respect to the shoulder. As I say, we want to begin with the discussion of the skeletal component and talk about some of the important markings, bony markings on these structures. We can see the proximal, the distal scapula. The scapula is the proximal bone in the upper limb. And then you'll notice that attached to it here is the humerus. We can talk about the attachments. The attachments of the humerus to the scapula are rather minimal by comparison to some other joints that we have and we'll be talking about. You'll also notice that even in this somewhat abbreviated image here, with respect to the scapula, you can see several processes here. You can see the clavicle, which is not part of the scapula, but below the clavicle is this coracoid process. You have an acromial process, both projecting anteriorly. And then there is another process, a third process on the posterior scapula that we need to talk about. But you can see both of these are rather peculiar projections of the bone. The scapula itself is an odd-shaped bone, but these both serve the purpose of muscle and ligamentous attachment. Indeed, there will be ligamentous attachments in this direction, here, and then there's also going to be a ligamentous capsule that we'll talk about later. You'll also notice, and again, just because this is a nice illustration, we'll see some more illustrations of this, but notice that the humerus, the proximal humerus here, has a little furrow or ridge running up the middle here, an anterior side here, and that's going to be an important furrow to accommodate a tendon along the long head of the biceps tendon. And then those tubercles, I'm not sure that tubercle is really the best term here, but these tubercles are also for muscle attachment, and we'll talk about, for example, the spinatus muscles that attach up here, and then the muscles that are responsible more for rotation of the humerus that attach at the lesser tubercle. So here you see a more complete image of the various skeletal components of the upper limb. At least we see the scapula, we see the coracoid process, the articulation with the clavicle, and the articulation of the scapula with the humerus. Now we'll talk about some of these other components as we proceed and look at them in greater detail. But you'll notice, for example, the humerus has a head. The head's up here, and then it has an anatomical neck and a surgical neck. And associated with each of those are several neurovascular structures that could be damaged if there were injury or trauma to this region. We indicated that we talked about the third process of the scapula being on the posterior side, and there it is. That's the scapular, sometimes called the scapular spinous process. There it is labeled the scapular spine, but that's the posterior process of the scapula. So be sure you understand the overall organization here. As I say, there are going to be ligamentous bindings in this region, over here. And then this entire thing, when I say the entire thing, I mean the entire shoulder joint or glenohumeral joint that you see here, will be not so robustly, but nevertheless encapsulated, especially on the anterior side, by ligaments. There are tendons that are sort of interspersed with those ligaments that tend to compromise the structural integrity of this joint. Arguably, this is the least robust in terms of integrity of the joints we'll be talking about. Now, there are some other tubercles and other components we'll mention as we continue, but in most cases, those tubercles that you see labeled or indicated there are for the purpose of muscle or tendon attachment. Let's begin with the clavicle. You can see the clavicle here has a sort of a mild sigmoid shape, an S shape. We saw previously, this is the clavicle and situ up here. So there's going to be a surface that attaches to the upper sternum, and then a surface that attaches to the acromial process of the scapula. But in addition, you can sort of see it flattening out here, that there's a ligamentous binding here, and then remember there are also going to be regions of muscle attachment. For example, the sternocleidomastoid muscle attaches medially to the clavicle. So kind of a sigmoid shape, necessary to accommodate the multiple complex attachments. Be familiar with what we call the acromial end and the sternal end. Sometimes hard to differentiate these in an isolated bone. I don't know, I think maybe I asked you before how many of you have broken your clavicle. It's a fairly common injury, happens in all kinds of situations. Usually involves some type of trauma from a fall. I know I was in a high school wrestling match with a baboon, and this baboon hominin threw me up in the air, and I came down. As far as I can tell, on my head. There's still some residual consequences of that. But I do remember waking up in the locker room and seeing the bone sticking out of my t-shirt, my little gym shirt they made us wear back in those days. And then I passed out again and woke up in the car on the way to the hospital trying to figure out what's happening. But this is commonly what happens. So you typically have proximal distortion of the bone superiorly by the force of the SCM. You can see the SCM attachment there. And then the weight of the distal limb tends to pull the lateral half down. So you often get something like this. And then they typically reduce the bone. I think we talked about this. How many of you had the reduction? Any of you had the broken clavicle and the reduction? Yeah. Well, how did they do it in your case?
They just put me in a sling. I didn't need surgery.
Well, I didn't. I don't think they. I don't think they do surgery to anybody. I guess unless it's really a lot of damage. But when they reduced it, were you conscious? Were you aware of that?
I don't think I was.
See, I had a statist that worked on me. But he puts his. Of course, I was only 15 or 16 years old at the time. But he puts his thumbs in the back and tries to tell you a joke, talk about something amusing, tries to divert your attention from the staggering pain you're about to feel. And of course, he tells the nurse to bring a bucket in case you vomit. And then it pops back into shape, and you're good to go. But when they put you in the sling, and I've heard others say this too. You mean like an elbow sling, or what type of sling are you talking about?
It's like those Walgreens slings that you just sit in.
Yeah, I don't understand that because, again, I think perhaps it was the sadism of the individual. But of course, what they put me in was this. And so, at 15 years old, you're walking around high school. And I have psycho-emotional scars from that too. But you're walking around like this all day. And so you didn't have that? You didn't have to?
Mine was fractured in the middle.
Oh. But I think that's the typical sort of, for a complete fracture, that's the typical. Although I've heard some more conservative treatment, and I don't. That's something you will learn much more about than me. It's, as you might imagine, not something I wish to revisit. All right, we see the scapula here in a little more detail, so you want to make sure you can identify the components here, and this is a rather complex and interesting bone, in some respects like some of the bones of the skull that we talked about. So there's an anterior surface and a posterior surface. You can see them there. The scapula itself is very efficiently constructed in as much as this region down here that you see labeled the subscapular fossa. It's very, very thin. In fact, the normal scapula is so thin and diaphanous in this fossa region that it's translucent. You can actually see the light through it. You can put your fingers behind it and see the shadows of your fingers on the other side. So it's very, very thin. Of course, that facilitates the lightness of the bone. But of course, a fossa represents a sort of depression. There's an anterior fossa, the subscapular fossa. And then on either side of the spinous process posteriorly, we have the supraspinous fossa and the infraspinous fossa. And these basically just accommodate the spinatus muscles on either side of that. We'll look at those a little later. And then again, that spinous process posteriorly. You can see on the anterior side, as we saw before, the anteriorly projecting coracoid process here, and that's the coracoid process here. I've heard students tell me that they remember that by remembering it looks like a snake head, and they think of the coral snake, and so it's a coral snake head, if that helps you. And that too is going to be for muscle and ligament attachment. And then we saw the relative placement of the acromion with respect to the clavicle previously. Looking at the scapula from a lateral perspective, you can see the glenoid cavity here. And one of the interesting things about the glenoid cavity is that of course is the depression, probably the cavity or fossa, that accommodates the head of the femur. It's very, very small. In fact, the articular surface, as we'll see, is just a very, very small disc. So there's not much of an interface between this scapular component and the head of the femur. And then there will be, I don't think we see them here, I think maybe I do want to talk about this a little bit. There are tubercles both above and below the glenoid cavity or glenoid fossa, and those also are for muscle attachment. So you can sort of see this labeled here in this illustration as the infraglenoid tubercle and the supraglenoid tubercle. And for example, the supraspinatus will attach superiorly. The long head of the triceps will attach inferiorly. I know you don't have this slide, but this is why individuals that teach anatomy courses can get so frustrated. Notice where the infraglenoid tubercle is labeled here and where it's labeled here. In reality, what you have, and it doesn't matter to me, it's not important for your purposes, but you have a little ridge here. And so that really, and I guess it should be called a ridge. And as I said, that is an attachment for the long head of the triceps. And so really, we'll just say that whole region to make things simple. We'll say that whole region, that entire ridge there is the infraglenoid tubercle. So don't worry too much about the variable little pointers and lines that you see in the literature. So we're looking also from a lateral perspective at this glenoid cavity. You can sort of see a blue surface here, and we tend to think of that blue surface as being the articular cartilage. That's really not what is indicated here, so don't mistake this particular illustration. They're just showing you the extent of the glenoid cavity. As I've indicated, we'll look at the little circle of cartilage a little later. It's not that big, it's much smaller, so I want to be sure you understand that this interface between the femoral head and the scapula is rather minimal. So we see here the illustration that we looked at before. We can see the two tubercles. Now note that this structure in the middle here, this little furrow or sulcus, is called, and here's labeled the intertubercular sulcus. It's also called the bicipital groove, and it accommodates the long head of the biceps tendon. And on either side of it, you can see these are sometimes called ridges or margins, but those are also sites of muscle attachment. For example, along those margins, the pectoralis major, the teres major, and the latissimus will all attach. Now, we indicated that the humerus itself has a head. You can see the head sort of in this region back in here, sort of projecting into the glenoid fossa. We've already talked about the tubercles, but the humerus itself has what is called an anatomical neck. That's the anatomical neck that you see there. And then it also has what is called a surgical neck in this region. If you had to guess, which of these is more prone, more vulnerable to mechanical trauma, breakage? Yeah, so surgical neck is much more vulnerable, and that's important to you because there are a number of critical neurovascular structures that run along or run very near to the surgical neck, including, for example, the axillary nerve that innervates, for example, the deltoid muscle, and arguably a portion of the triceps. We'll fight that battle a little later. But any injury to this region could damage both that axillary nerve and, for example, a circumflex artery in this region too that wraps around the humerus at this point. We're looking at those two tubercles again. Here's the greater tubercle, the lesser tubercle here, and you should know that the greater tubercle is the site of attachment for the spinatus twins, the supra and the infraspinatus muscle. We'll talk about their function in just a moment. And also the teres minor, which is probably less important and more critical for rotation of the humerus. The lesser tubercle that you see here in the middle is the site of attachment for the subscapularis. And the subscapularis is the large muscle on the anterior surface of the scapula. And so it's going to reach over to here and also function as an adductor and a rotator. Now, by the way, as we continue our discussion, it's important to keep in mind the way that these slides are organized. They're heavily redundant. In fact, my guess is that as we talk about most of these things at the beginning of our discussion in each subsection, we can just sort of zip through the hints. So I just want to alert you to the fact that students sometimes complain, you've given me 14 slides of the same thing. I'm aware of that. I want to make sure you have as much information as possible to understand the location and relationship of the anatomical relationship of these structures. So notice this is labeled appendicular muscles. So generally when we talk about an appendicular muscle, we're talking about a muscle that is attached to the scapula and or the humerus that has some distal attachment. By distal attachment, I mean to the spine, to the neck, to the head. And we differentiate these muscles, for example, from intrinsic muscles. And we'll talk about some intrinsic muscles that lie within the shoulder, lie within the upper limb and articulate usually it's going to be the humerus that is articulated. So these appendicular muscles would include pectoralis major and minor. You can see the pectoralis major in the left illustration over here. You can see it's a massive muscle that attaches to everything from the clavicle, the sternum, all the way down to the rib cage. It even has scapular attachments in some cases. And then we're going to look at a little Ackman video in just a moment where the distal attachment to the humerus is, but this is a very powerful rotator and adductor of the humerus. Here's the pectoralis minor here. This is usually described as a scapular depressor and stabilizing muscle, but note that it lies deep to or inside the pectoralis major. The subclavius is a little muscle up here, probably also important for depressing or lowering the scapula. And then finally, among these appendicular muscles, we have the serratus anterior over here on the right. And the serratus anterior is a very important muscle in the sort of protraction, stabilizes protraction of the scapula anteriorly. And we'll talk about some of the other important anatomical aspects of these muscles in just a moment. Now remember that pectoralis major is one of the muscles that attaches to the margin of that bicipital groove. In fact, the pectoralis major attaches to the lateral lip. And the lateral lip, and I can promise you on your clinical evaluations, they're going to ask you to check for tendinitis in this region. And so you need to know that that bicipital groove is not over here, it's anterior. And so when we talk about the lateral lip, we're talking about the more lateral side of that, bicipital groove. So we've talked about the subclavius and the serratus. Just to understand, the serratus gets its name from its sort of serrated or scissor-like attachment to the ribs there. And it's primarily important for positioning the scapula, again, in a protractive or anterior perspective. Still looking at the appendicular muscles, there are a number of these posterior muscles, including, and again, remember how we're just defining extrinsic. We've used these terms before. Extrinsic just means that this is a muscle that somehow moves either the scapula or the humerus, but has a distal attachment. Distal attachment could be to the spine, the neck, usually it's the spine or the neck. It could be the sternum if it's anterior. So these would include, if it's on the posterior side, these would include the trapezius, very powerful elevator of the scapula, the latissimus dorsi, also posterior, that attaches from the spine and the thoracolumbar fossa inferiorly up to the humerus. We'll look at that attachment in more detail in just a moment. The levator scapula, we've encountered that before, again, sort of attaching to the cervical, the transverse processes down to the scapula. And then the rhomboids, we'll look at the rhomboids in just a moment, but these also help primarily to both the superior and inferior act to elevate the scapula. Now, here we have some intrinsic shoulder muscles, and we'll look at these in more detail later, but in general, the intrinsic shoulder muscles on the posterior side are the rotator cuff muscles, the muscles you've probably heard in association with athletic injuries, throwing injuries, that sort of thing. You need to know these thoroughly. We'll come back to them a little later and talk about their organization and function. But again, these would include the spinatus twins on either side of the spinous process on the back of the scapula. One important for abducting, the other more so for rotation. Teres minor, we'll look at its position, and then the subscapularis is on the anterior side of the scapula, but forming, unfortunately, and complicating our anatomical analysis, the posterior wall of the axilla. We'll come back to that later. But this is an anterior scapular muscle that covers most of the anterior fossa of the scapula. So as I've indicated, a lot of this is redundant. Just be sure that in these cadaveric images you can identify the levator scapula. We've seen that before. Here are the rhomboid major down here. This is the rhomboid minor that's sort of colored greenish there. You can see the teres major, sort of a powerful adductor. We'll look at the relationship. It sort of interferes with the pectoralis attachment, the latissimus. latissimus attachment 2. So we're going to use later on. Do you remember how much fun you enjoyed learning about the triangles and the regions of the neck? You're going to have a similar issue with respect to the shoulder here, and what you'll find is that the two heads of the triceps here, we won't worry about the medial head, the two heads of the triceps and the two teres, the teres brothers or teres sisters there, don't mean to be sexist, can form a number of little spaces. For example, you can see a space there, you can see a space there, there's going to be a space down distal on the arm, and we'll come back to those. But I think for now, what is maybe useful to think about is this gap between the two teres and the gap between the lateral head and the long head of the triceps as forming these critical spaces through which a number of important neurovascular structures pass. And you can see that kind of very neatly here. We've talked. You can see the rhomboids again. These are sort of posterior muscles. The levator scapula we've talked about. The trapezius, massive muscle, important for positioning the scapula both superiorly and for retraction of the scapula. And then the deltoid is a very powerful abductor. We'll talk about it, but the deltoid works in concert with the supraspinatus muscle to enable you to abduct your humerus. We've been introduced to the trapezius in our discussion of the back, for example, so just remember that the trapezius, you know where it is. You can see it labeled over here, but make sure you realize that it's innervated by cranial nerve 11 there. That was the spinal accessory nerve. And be aware of the curious way I've annotated or I've described it. So when it says cranial nerve 11 and the anterior rami of C3 and C4, that doesn't mean, as you well know, the cranial nerve 11 is a component of the cervical plexus. It means that in reality, the trapezius is innervated by components of both of these. Remember, that gets us into a discussion of the spinal accessory nerve, which we've already dealt with. So just be aware of that. The deltoid down here is going to be innervated by the axillary nerve, and we can see the deltoid labeled over here. Now, as the paragraph indicates there, abduction of the humerus is achieved by the actions of both the deltoid and the supraspinatus. Supraspinatus is a rotator cuff muscle, relatively weak. It runs right over the top of your groove there, right on down into the greater tubercle. And the reason I mention this is because oftentimes, I know a lot of you are interested in maintaining your physical fitness, and I'll see individuals in a gym on one of, I guess they're called wing machines. If you've seen these things, you put your arm in here and then you elevate. And the assumption is that, again, just like the young folks will go in and put as much weight on the barbell as they can to do a deadlift, they'll load up the machine, and assuming that there's one muscle that powers that entire, what is it called, chicken lift? But that's not true. What you need to appreciate, both as a PA and just as appreciate the general kinesiology here, that initial abduction is achieved by a fairly weak muscle, and therefore, if you load up that rack, you're likely to tear this muscle before the deltoids can kick in. And the deltoids, of course. So again, what you would advise your patient to do is limit the range for the deltoid and be much more careful in that initial abduction. We've talked about the levator scapula. Notice the levator and the rhomboids are both innervated by components of the dorsal scapular nerve. So again, the dorsal scapular nerve and the cervical plexus innervate the levator, and the same thing is true for the rhomboids. Primary innervation, though, is achieved by a branch of the brachial plexus. So do we understand the distinction between the brachial plexus and the cervical plexus? Brachial plexus is C5 to T1 or C5 to C8. The cervical plexus is C1 to C4 or C1 to C5. So what we're saying is that in both cases, it's primarily a nerve from the brachial plexus that is innervating the muscle, but there are also contributions from the cervical plexus. And this is just, well, actually, this is a discussion of the two spinatus, innervation to the two spinatus. And these, both of these muscles are innervated by the suprascapular nerve that you see over here. Look at the illustration here. The suprascapular nerve is going to run right through that little furrow right there. The teres minor is innervated by the axillary nerve. The deltoid is also innervated by the axillary and arguably a component of the triceps. And then the long, yeah, we'll come back. We'll finish the rest of this a little later. But again, supraspinatus, which we know, supraspinatus muscle important for initial abduction, lies above the spinous process, innervated by the suprascapular. The infraspinatus below the spinous process on the posterior side of the scapula, also innervated primarily by the suprascapular. So here we're looking, and this slide is labeled posterior scapula, but what you can also see here on the anterior, this is anterior, this is posterior. Here's the subscapularis, so all of that is subscapularis. Here's the coracoid, the acromion. And then at the top there, you can see that very delicate, I suppose I'm exaggerating it, but that delicate supraspinatus running over the top of the glenohumeral joint there. And then on the posterior side, once again, there's the supraspinatus, infraspinatus, and then down here is the teres minor and teres major. Now, I mentioned that I would encourage you to sort of think about the openings, the spaces, the intervals created by these two heads of the triceps here and the two components of the teres, one of which we see sort of clearly here, sort of there, and running along there. The first of these spaces is called the quadrangular space, and as I indicated earlier, I've given you about a dozen, or at least 3 or 4 different images showing the same thing here. So we have what, 1, 2, 3, 4, at least 4 different images showing the same thing. But here we go, and be sure you understand that I'm not concerned too much about your ability to tell me the margins of these spaces. I'm more concerned that you know where they are, their relationship to each other. There are going to be 3 of these: a quadrangular space, a triangular space, and a triangular interval. Know the relationship, and then most importantly, know the structures that pass through them, and why that would be important if there were any damage or trauma to these regions. So this is the large one. This is called the quadrangular space, and you can see once again that we have, and in this case, the arm is somewhat extended. We have the 2 heads of the triceps, the lateral and the long head, and then you have the teres minor superiorly and the teres major inferiorly. And then running through that space between them is the axillary nerve and the posterior circumflex humeral artery. And remember, these 2 structures also pass along the surgical neck or around the surgical neck of the humerus. They're vulnerable in that way as well. So the debate, should you entertain it, is over whether this margin should be designated as the lateral head of the triceps. What else could it be as you look at it there? What else would that be? The humerus here. So I don't care. You can pick whatever. So obviously, if there's any narrowing or damage, swelling, significant trauma to this region, that would involve potentially not only the blood flow, but also the innervation to the deltoid. You might see weakness there. That's not not terribly common. But also there would be damage to the teres minor or innervation of the teres minor as a consequence of trauma to this region. The little green region that you see there then is the quadrangular space. And you can see the axillary nerve passing in that region and the artery just below it. This, medial to that, over here, is sometimes called the triangular space. This is the triangular space here, and then this is the triangular interval here. I don't know, I can't think of any mnemonic. There was a nursing student last semester who would just come up with these mnemonics on the fly. She always had some crazy way to identify these structures or know the relationship. But in any case, notice it's the radial nerve and what we're going to call the deep brachial artery that passes in this triangular interval here. And then the triangular space is a little less important, but that yields the scapular circumflex artery. By the way, there's another point of confusion that you can reflect upon just before our break. And you would think that anatomists over the eons, since the time of Hippocrates and Galen and so on, would have come up with the appropriate and common definitions and terms for all these structures. But in this illustration, notice this artery right here. It's called the transverse cervical artery. Everybody see that? You're going to have at least two illustrations later calling that a scapular artery. And I don't care which. If your question is, and I'm sure it is there a legitimate distinction between the transverse cervical and the dorsal scapular artery? Yes, but that's debated, so we won't get into that. You can call this either one, so just anticipating that problem, because you have a nice illustration of it here. This, the transverse cervical and the deep or dorsal are the same artery as far as I'm concerned. But what you will notice is there's extensive anastomosis with this artery in the posterior scapular, the suprascapular artery. So there's a lot of branching perfusion posteriorly. Now, with respect to these spaces, if you have a geometric turn of mind, I'll let you muse on this illustration. This will give you see if you can figure out what they've done here. These, you can see the quadrangular space. So what would the A and the N stand for? Yeah, it's artery and nerve. See how good some of you are. Probably takes me weeks to figure something like this out. But there's the artery and the nerve, and then you can see this quadrangular space, the triangular space, and the triangular interval. And then what they've done in a color-coded sort of way is given you the structure that bounds each. So for example, the blue would be the long head of the triceps. The green would be the teres major, and so on. So if that helps you find, if it doesn't, you can forget it. But as we pointed out, the triangular space, for purposes, passes the circumflex scapular artery and vein. The triangular interval, very, very important, passes the radial nerve. We're going to talk about the radial nerve, a very critical structure, as well as the deep artery of the arm. The deep artery of the arm is important because it perfuses, at least it gives rise to the perfusion to the posterior compartment of the arm. Remember, the arm is the structure between the shoulder and the elbow. All right, let's take a break and we'll resume.